Welcome everybody to another episode of Dr. Matt and Dr. Mike's Medical Podcast. I'm your host, Dr. Mike Todorovich. I'm joined by my co-host, Dr. Matt Barton. Matty, how are you?
Good morning, Michael.
How's everything been?
Different.
What do you mean?
I'm a dad version 2, father version 2.
Right. Is it different second time around? I've got 2 kids.
Yeah, well,
it was different second time
in some
around.
ways.
Yeah.
Like, you know what to expect.
So 2 girls.
2 girls now.
Right.
So just had on the 29th of May, we had a daughter called Halima.
Yep.
And the birth went well.
Cool.
So it was under 4 hours. It was quite quick.
That is quick.
So Sunday midnight, my wife woke me up and said, I may have some contractions here. And I was like, it's all right. Wake me up when it gets serious.
And you rolled over and back to sleep you went.
No, it was probably within 10 minutes that it became active kind of contractions. And then by the time we were in the car on the way, I was timing it in the car.
And?
They were maybe every 2 minutes, every 2 or 3 minutes. And they'll last in about 40
was this?
seconds. This was just before 1 a.m.
Oh, yay. What a good time.
And so by the time we got to the hospital, and I mean, it actually worked out well in terms of availability of staff and so forth at 1 a.m. on a Sunday morning.
Yeah.
Or Monday morning. So we arrived. She was already 5 centimeters by the time we moved through.
It's a small baby.
Yeah. By the time
cervix. Sorry, yes.
By the time we moved through the assessment induction part of the presentation, we then moved to the birthing ward.
Did you say, I've got this? And
well,
then,
actually,
did the midwife say,
one of the midwives was an
here?
ex-student.
Oh, really?
Yeah. So I knew them.
All right.
Which was, it was great. She did a wonderful job.
Oh, that's good.
And it progressed pretty quickly.
Wow. And obviously no troubles, because I've seen your beautiful little girl, and she's happy, healthy. She's a chunky monkey, which is good.
Feeding well, pooping well, sleeping relatively well.
Wow. So better than me in all 3 realms. So
yes, that's right.
That's great.
So it's gone. I mean, you forget what the newborn days were like.
It's tiring.
Like they poo a lot.
They poo a lot.
You get used to a 2-year-old.
Yeah.
And they're pooing maybe, I shouldn't say pooing. They're changing nappies every 4 hours-ish, right? This one's like every hour and a bit.
Yeah, and the poo's not great. No substance.
Doesn't smell though. That's a good thing.
That's true. Yet, until the gut flora comes in properly, and then give it a month. And
I think it's just milk. I think the milk doesn't really smell.
Oh.
I think once you get to solids.
Yeah, I think that's when the gut flora really starts to kick in too. So, well, congratulations.
Thank you.
It is a big thing. Like I said, I've got 2 kids, and it's not easy. But luckily, I get to sneak away every now and then into our studio where we are right now to do podcasts.
Yes.
And today, our topic is epithelia. And epithelia is one of the 4 tissue types of the body, right?
You know what the term means?
No. Well, epi means on.
Yeah. Thelium, I think, means nipple.
Nipple?
Yeah.
So it means on the nipple. Is it because that's where they first sort of classified the tissue as, hey, that one looks different.
Maybe.
That tissue looks different.
Maybe. I should have looked into it.
Yeah, instead of asking me straight up, what's it mean? All right, so epithelia. Now, I know that very recently, your mum, who lives down in Sydney down in New South Wales way.
So we're in Queensland.
That's right. Matt and I are in the northeast of the country. Beautiful, sunny Queensland. Best part of the world, I think. Sun cancer capital of the planet.
Yes, there we go.
Which is quite relevant to today's conversation and relevant to your mum. She had a skin cancer that had to get cut out, and it was pretty aggressive, right?
Yeah, so my mother, actually I inherited my skin from my mother. So that is poor quality skin.
Yes.
I mean, it does its job, but it's not so good for living in a country like Australia.
Of the job.
I think we're designed, we have skin for Iceland or northern Scotland.
Yeah, or underground.
Underground. That's right. So my mother has had some skin cancers beforehand.
Yeah.
So she gets a regular, I think, yearly dermatology examination.
Yep.
And I think this particular one, this is a year ago, she went and it was present, but there was just too many for the dermatologist to burn off or freeze off. So this one was
across
on
the body, or
off face particularly.
right?
So this one on the nose, and she was like, "What do you think of this?" And the dermatologist was like, "Oh, we could be here all day." So left it. So
Was that common? Just leave it?
I think it was just. I think once you get to an age of 70,
Yeah.
there's a lot of skin lesions that look
just putting out
questionable.
fires.
That's right.
Yeah.
So this one was located on the left nostril,
Like
kind
just
of external.
above the, yeah.
Kind of in that fold between the maxilla and your
The cheek and the nose. Yeah.
And Mum had just noticed it was slightly worsening as the weeks progressed. Now,
worst thing in the sense of just getting larger.
Getting larger and maybe more scaly.
Right.
So it wasn't pigmented, it wasn't a melanoma. That would be a concern if it's a pigmented lesion, but this was just a scaly one, which is either a squamous cell carcinoma or a basal cell carcinoma.
Yeah.
Which we can talk to a bit later. Now, you can get creams, and I actually have cream myself for this, and it's basically like a chemotherapy.
Right.
But it's a cream. So you just put it on for 3 weeks, and it basically knocks off all the highly mitotic cells that you put it onto.
Wow.
So I think she even used that, but it didn't kind of do the job. Now, in the town where my mother lives, you can only get to the specialist once a year if you're lucky, because that's how booked out it is. Okay, so regardless, you're not going to get in. But Mum started to notice it was getting quite bad. She contacted them, and they're like, we can get you in at this date. And I think she sent a photo, and they were like, "Oh, just get a biopsy from the GP." But the GP was even reluctant because it was in a very awkward position.
Yeah.
So I think they got. I think
groove of the nose.
Yeah, I think they got some out, and they found that it was a SCC, squamous cell carcinoma. And by the time she got back to the dermatologist, which I guess was April this year.
Yeah.
The dermatologist was like, "Yeah, it's definitely SCC," and I'm guessing it's kind of left its epidermis.
Right.
So we would want you to go and get it cut out by plastics. Or not plastics, by basically an oncologist surgeon in Sydney.
Right.
Now that...
Because they were worried that it had invaded other tissue.
Yeah. And so she went to Sydney, which is the nearest capital city, and they do a procedure where basically they're taking out tissue and doing histological analyses almost in real time just to see if they got margins.
Wow. Yeah.
And by the time they'd finished that, she'd probably lost half of her left side of her nose.
Wow.
Once they cut all the margins out.
Wow. Wow.
So I have seen the pictures. Have I showed you the pictures?
Yeah.
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 So you can actually see right into the septum.
Yeah. It's quite gruesome.
So quite a significant incision.
Yes.
And so what then needed to happen is the plastic surgeon needed to come and reconstruct the nose. And so the surgeon took a big flap from the forehead, so like a big chunk of tissue from the forehead, spun it around and attached it to that hole.
Wow.
And the reason why they did that is so it could take, so it's called a pedicle, and so that takes the blood vessel with it. So that chunk of tissue is still fed with the original blood vessel.
Yeah.
Does that make sense?
Yeah, yeah.
And so they reattached it, and that way that tissue is being fed well by a blood vessel. And so
amazing.
All the other tissue that it's trying to anastomose with, that they need to kind of build their own angiogenic supply. Does that make sense? So if you didn't have that blood supply, you would be at risk of having necrotic tissue.
Yes. Last thing you want in both places.
But luckily that blood supply fed the whole pedicle and then all the neighbouring where it kind of had the join.
Now, how's she doing now?
So that was operation 1.
Oh.
Operation 2. And so when you saw that was quite confronting because there was a big kind of bridge of tissue.
Yeah, across her face.
And then operation 2 was to rebuild the nostril, so they had to get cartilage from rib.
Wow, really?
Because otherwise the nostril would just be closed in. So they had to build the nostril out again. That was operation 2. Operation 3 was to remove the bridge out. So it was basically to remove all the other parts.
Why the bridge?
Because it was still connected up to the forehead.
Right.
So they had to kind of cut all that
Oh,
away.
not the bridge of the nose. You
No.
mean the skin bridge
Yeah.
between the
The tissue
forehead and
bridge,
the nose.
yeah.
Gotcha.
Yeah.
Wow. So they had to cut that away. So that was number 3.
3 surgeries, yeah.
And now how is she doing? How's she looking?
Great. I mean, like you'd notice,
Sure.
but if you were walking past in the street,
Yeah.
you wouldn't.
Wow.
So the plastic surgeons are amazing.
Oh, they are amazing. And so she had a squamous cell carcinoma.
Yeah.
So this is a cancer of an epithelial type,
Correct.
which is the topic of today, epithelia.
Yeah.
And I think once we start going through terms, it will make sense what a squamous cell carcinoma is, right?
Yeah.
So should we begin by talking about the fact that epithelia is one of the 4 tissue types of the body, and that you could basically take every tissue. So when we look at tissues, they're comprised of cells that sort of come together to work
Similar function.
similar function. And there's 4 main types. There's nervous tissue, there's connective tissue, there's muscle tissue, and there's epithelial tissue. We've done a podcast, unsurprisingly, on all of these except today's topic.
So we've done
Epithelia.
a podcast on tissue
Yeah.
that kind of summarizes each one briefly.
Yep.
We've done a specific one on connective tissue and of muscle. Not of nervous, I don't think.
Well, we've done the nervous system, but
But
not
not
nervous
nervous
tissue explicitly.
But epithelium is an important one. And
Really
that's-
is.
And that's for today.
Yeah, and many students need to go through the epithelium, need to understand it and apply it. And that's what we're going to do. We're going to give you the information that you need to understand epithelia. So one of the 4 tissue types. Now remember that you could probably broadly classify each tissue, and correct me if I'm wrong or add something, right? So I'm just doing this off the top of my head. Muscle tissue is there to perform work. It allows for movement to happen of some kind, right? So the muscles
Contractile cells.
so muscles of our skeletal system move the body. Muscles in our blood vessels move blood, and the muscles of our heart move blood. So we've got multitude of different
And in
muscles.
my wife's case, smooth muscle of the uterus, which moves a baby out.
Very true. So then you've got connective tissue.
You say cardiac tissue, heart.
I did say that,
Like
yes.
that. Okay.
You've got nervous tissue. Basically, they're for communication. So understanding what's happening in the external, internal environment, and then being able to respond to it. Sorry, did I say connective or nervous?
Nervous.
Okay, nervous. You've got connective tissue, which is to wrap, bind, and anchor. So sort of holding things together. And then finally, you've got epithelial tissue, which lines hollow structures. It basically forms barriers between environments. That's how I describe it.
So covers body surfaces.
Yes.
So that would be the skin, like
Yes.
we explained, when it goes wrong, skin cancer.
Yep.
Then it lines body cavities.
Yes.
So that would be like the abdominal cavity,
Anytime
the
there's a
thoracic
hole.
cavity. But then it also is the surface of organs, right?
Yep.
So it generally is referred to as serosa many
Yep.
of the time, right?
Yeah.
Um,
Not the organ itself, but usually the membrane that surrounds the organ.
right, yep.
Yeah. Like
And
the organ itself won't be necessarily epithelia.
And then pipes within the body.
Yep.
So that could be your respiratory pipes.
Yeah.
So on the inner part of that, so that would be where the air is.
Yeah. Any surface facing an environment.
The gut.
Yep.
But also blood vessels.
Yep.
Okay.
And also the ventricles of our brain.
Yep.
So anything hollow.
And then you also have glands,
Yes.
which are epithelium.
Yes, very true.
So that then is generally pretty much it.
Yeah, and its function, if you think about it, right? Broadly, if you're going to have a tissue type that's exposed to an environment, its job is to interact with that environment in some way. So maybe the environment is damaging, so the epithelia needs to be protective. Sometimes the environment needs to provide nutrients, so it needs to be absorptive. Sometimes the environment needs something to be released into it, so sometimes epithelia will be secretive. Does that make sense?
And needs to move things.
Needs to move things. Sometimes gases need to be moved, so it's going to play a role in diffusion.
Okay,
So
yep.
the epithelia, its function really is determined by where it is. But also it's very important to state that with epithelia, there's this saying that we like to say, which is form equals function. So you can actually look at the structure of the epithelia and it tells you what it does. That's
Yeah,
pretty
yeah,
good.
yeah.
Which I
And when you say you
love.
look at it, we're basically doing it with a microscope and
Histologically.
Stains.
Yes. So looking at the structure of the cell itself. So broadly speaking with epithelia, like we said, this tissue lines hollow organs and lines structures, separates out environments. But it's important to say that it's avascular.
Oh, okay.
It doesn't have a dedicated blood supply. So what does that then mean to you in regards to, because all cells need to be fed. So if it doesn't have a blood supply to it, how does it get fed?
Through diffusion.
So
through, I guess, extracellular fluid.
Yeah, so where is the blood supply generally that's going to be feeding epithelia? What of the 4 tissue types will it be moving?
In connective tissue.
Yeah, the underlying, because am I wrong that all epithelia at some point will be bound to connective tissue?
Okay, that's good, because I'll just quickly mention, I was going to mention this, I was trying to figure out how I can bring this into it.
Right.
But when we look at epithelial as a classification, before we go into classifying it by shape and layers,
Yep.
Another important principle that all epithelium have are the surfaces of the epithelia.
Right.
Okay, so you have the top surface that faces the external environment.
Right. So this might be the surface that faces the hollow inside of our stomach,
Yep.
or esophagus, or blood vessel,
Yep.
or urethra,
Yep.
or ventricles. But that's
Or the outside world if it's the skin.
Oh, right. And that's
Yep.
called the what?
That's called the apical surface.
Apical. Yeah.
Okay, so that is one principle, that it has to have an apical surface, that surface that's facing outwards or externally.
Yep.
Okay. Then there are the surfaces on the side, so the lateral surfaces,
Okay.
and this is where it adjoins its neighbour.
So other epithelia.
Yeah, because in most cases, epithelium is in a sheet, so they're kind of like like a neighbourhood or houses next to each other.
Bricks or bricks in a wall.
Or a bricks and wall, that's right. And so where they meet in their adjoining neighbour, not on top of each other, but next to, that's the lateral surface. And then we have the underneath, which is the basal surface.
Basal, like basement.
Basement. And
Yeah.
then
what's the basal surface connected to?
The basal membrane, or what's the term?
Or it could be other underlying epithelia too, right? If it's many layers.
Yeah, but when we specifically refer to the basal membrane, I guess, that's the base of...
So the very bottom or most deep epithelial layer of cells, that's going to be attached to a basal membrane.
Yeah, which is connective tissue.
Right, that's
and then that
tissue.
would then be in continuation with connective tissue now.
Okay,
and so
that's
when
where the vascular supply is.
Yep.
And the nervous supply?
Yeah.
So that means that do epithelia have any not blood vessels,
Nerves,
we know it's avascular, but it's got nerves that can come from the connective tissue up into them. And that gives us sensation, for example, receptors for mechanical,
so that
chemical.
That could be bare nerve endings.
Right.
So that could be
nociceptors.
Or
temperature receptors.
There may be specialized endings on those nerves, which are actually epithelium as well. So when you talk about mechanoreceptors, but also taste receptors, light receptors, what else could you have? I'm just trying to think of all the special things.
Chemical, taste, light, pressure.
Yep.
These a whole multitude.
They're epithelium as well. So you've got, let's say, like...
modified epithelia.
Yeah, so you might have certain pressure receptors in your skin that pick up vibration or displacement. They are like, let's say, layers of onions, which have epithelium in them. And through the displacement of those mechanically, it would cause...
the layers around the end of the neuron, right?
Yeah.
Okay, so it's epithelia, modified epithelia lining the outside of the receptor of the neuron. Right.
And so by the displacement of those layers or of those cells, epithelial cells, they can change the way that, I guess, ions move through them, which can then lead to graded potentials and then ultimately lead into an action potential into that neuron.
Yep.
And then that would be processed as a signal. You know, if it's going to be mechanotransduction, it would then be movement.
Okay, so you basically highlighted that one function of epithelia can be for us to interact with the environment.
Yes.
To detect what's happening.
Special receptors, that's right.
Either in the external environment or the internal environment. Okay, so we've got that. I just want to go back very briefly again to the fact it's avascular and why it's avascular. Because people might think, why doesn't it have a dedicated blood supply? And I think there's a couple of reasons there. One, if you've got and I'm just working off first principles here. One, if you've got a blood supply that is so superficial, so right at the surface, because we know that epithelia is right at the surface, right? It interacts with the environment. If you've got a vascular supply so close to that surface, any damage, trauma, you're going to bleed, right? And this is actually something that we see when we move to dry places and we get blood noses. Our nasal cavity, which is lined by epithelia, it does have a blood supply that's very superficial. It's still not in the epithelia. It's just we're very thin epithelia there. And when it dries out, the epithelia cracks and we bleed out of the nose. Now, if that was in other organs and structures, it would bleed out all the time. We don't want that. That's the first reason.
I think maybe the exception there, though, is the blood vessel that is in such close proximity to your mucosa.
Yes.
Partly is a function of warming air.
Yes.
Or
the
humidifying as
mucosa
well.
in the nasal.
Yeah.
Yes, exactly right.
Whereas if you compare it to the skin, you really don't really want blood that close to the surface because of the concern of lacerations and losing blood.
And that's my second point, is that when you look at the skin, for example, the type of epithelia that's there is epithelia that's supposed to protect us from what's happening outside. And so it's not uncommon for us to get scrapes, hits, knocks, bruises, things like that, where the epithelia is going to get damaged. And one, you don't want to bleed out. But two, you don't need to supply blood to cells that aren't alive.
Yeah.
And many of the epithelia right on the surface of protective areas are dead.
Yeah.
And so they don't need a dedicated blood supply. Now, I think this is a nice transition for us. Again, mind the pun.
Transitional epithelium.
Yeah, you'll find out later on. This is a nice transition for us to talk about the way that we can classify epithelia in regards to two things. What are those two things, the way we classify epithelia?
So that's through the shape of them?
Yes.
And through how many layers they have.
That's right. Shape and layers. Let's go through the shape. Two main shapes?
Three main
shapes.
Yep.
Sorry, yes. Okay, so what are the three main shapes?
Squamous.
Right, so that's squished like a pancake.
Yeah, so the width of the cell is greater than the height.
Gotcha.
Yeah.
Yep.
Cuboidal.
Right, so just a square.
The height and the width are the same.
Yeah.
And then columnar.
Just like a column.
The height is greater than the width.
Makes sense. Yeah. So they're the three shapes.
They're the three shapes.
And then the second one is layers. Now there's only 2 layers, or is there 3?
No, there's only 2.
Well, there's 2, but there's one
there's 2 in definition.
There's one that sort of sits between.
Yeah, but that's going to be a separate caveat.
Okay, let's do the 2.
Okay, the 2 is 1 layer thick.
Okay, what's that called?
Simple.
Like you?
Yeah.
Right? So 1 layer thick.
Simple. And then stratified is 2 or more.
So stacked on top of each other like bricks.
Yep.
All right. And that's stratified.
That's stratified, yeah.
But there's also pseudo-stratified.
Yeah, so now we can add... So, okay, before we get to the exceptions to the rule, let's just put together some of the way they will be termed. Okay. So if we go... What were the 2 again?
In regards to the layers?
Yeah.
Simple and stratified.
Yep.
Yep.
And then the shapes?
We've got squamous, squished, cuboidal, cube, columnar, like a column.
Okay. So then the categories, let me just count them. 1, 2, 3, 4.
That's 8, I think.
1, 2, 3, 6. 6. Call it
sure?
6. Yeah, before I bring in the caveats.
Okay, let's do it.
So we'll start with the simple. So we're going to have simple squamous.
All right, so that's 1 layer of flat squished cells. Yep.
Simple cuboidal.
1 layer of square cells.
Yep. And simple columnar.
1 layer of column-shaped cells.
Yep. Now we go into the stratified.
Yeah.
We have stratified squamous.
So many layers of squished cells.
Yep. Stratified cuboidal.
Many layers of square-shaped cells.
Okay. And then stratified columnar.
Right. Many layers of column-shaped cells.
Right.
So there's 6.
That's the 6.
All right.
Now we have the caveats, which are the exceptions to those 6.
All right. What's the term that we use?
Okay. So
yeah,
we may have a situation where if you were to look at the tissue, these epithelial tissue, down a microscope,
right,
you may look at it and go, that's stratified.
Okay. So it looks like there's many layers.
Yeah. And that's partly because the stains that they would use commonly in histology would be a stain for maybe cytoplasm and nucleus. Okay, so when you see the nuclear stains, you can kind of just see these purple dots.
Yep.
And you can kind of just see them lined up.
Right. And you'd think if there's many layers, you'd see multiple dots on top of each other.
Correct.
But in this case, even though it looks like there's many layers, you only see one nuclear stain in a row.
That's right. So when you looked at it quickly, you'd go, that's stratified because it looks like they're on top of each other.
Right.
Okay. But then you did a real close investigation and you actually find that they're columnar, but they're kind of still single in appearance.
It looks like they're overlapping in a way.
Yeah.
So that's, what's the term we use there?
Pseudo.
Pseudo meaning fake, right?
Correct. So pseudostratified.
So it's pseudostratified.
That's the first caveat.
Okay.
Is a pseudostratified epithelium.
Yeah. Or
sometimes, if you want to be technical, I don't know if there's an exception to this, but the example that we commonly would give is pseudostratified columnar epithelium.
Yes, because what we find biologically or histologically is you don't really have pseudostratified cuboidal or squamous. It's simply just pseudostratified columnar, and that's got to do with the shape of the column. Okay, so that's given us 7 so far.
Okay.
What's the 8th one?
Now the 8th one is transitional, which means it's changing from one shape to another.
Not the one epithelia, but the layer. The shape changes as you move through the layers. Is that right?
Yeah.
So give me an example here.
And so this would be dependent on the volume of what's in the organ at the time. So if the organ is empty, so if it's an organ that holds something,
like your heart,
anyway, let's say it holds a substance.
Right.
If that organ is empty with that substance, it's the epithelium are brought closer together, so that they're
lower surface area,
and they kind of bounce back to a particular shape. But as this organ starts to fill up with a fluid and gets bigger and bigger and it distends, it stretches the cells out. And so if you were to look under the microscope when it's been filled, it would look maybe more squamous.
Okay.
Whereas when it's an empty organ, it would be
or columnar cuboidal.
Yeah, that's right.
So basically what you're saying is if you have a look down the microscope of organs that can distend and contract or change their shape, like a bladder, for example, even though we'll go through specific examples soon.
Correct.
I'm sorry for bringing that up because I know that you probably were intentionally not saying it.
You ruined it.
You'll see that going from the basal side to the apical side of these stratified epithelia, so there's many layers, it's probably going to be more columnar at the basal layer and then probably more cuboidal, and then as we get to the apical layer it's going to be more squamous. And that's the transition of the epithelia that you see in these types of regions that can change their shape.
Yeah.
So what we've got is we've got simple squamous epithelia, simple cuboidal epithelia, simple columnar epithelia, pseudostratified columnar epithelia, stratified squamous epithelia, stratified cuboidal epithelia, stratified columnar epithelia, and transitional epithelia.
Yep. Now, there are a few additional names you can throw at the front of these terms.
Oh, okay.
Because they have additional specialization.
Yes.
Now, features.
Yeah.
Now, when we go to, remember I said some important principles of epithelium?
Yep.
So we have one being the basement membrane. We have their close proximity to each other. That's number 2. Number 3 is the surfaces.
Right.
Now, on the apical surface, sometimes there are going to be specialized appendages.
Yep. Or features again.
Or features.
They can interact with the environment it's exposed to.
Right.
Yeah.
Now, one of them could be little...
hairs?
Eyelashes.
Right.
But that's where the name comes from, cilia.
Oh.
So cilia are little projections.
You know, when people talk about you and I, they say, you're sillier than I am.
So cilia would have projections from the apical surface out into the lumen, let's say.
Yeah.
Okay.
Lumen means hollow inside, dear listener.
And so that would give a name to it. So now you could have, if you want to be technical, you could be pseudostratified ciliated columnar epithelium.
Right. Pseudostratified. So it looks like there's many layers, but there's not. columnar, so the shape is
But
column.
they got ciliated in there.
Yeah.
Or cilia. You got cilia is in the name as well.
So wait, what's it called? Pseudostratified,
Ciliated.
ciliated. Yeah.
Columnar epithelium.
Oh, columnar epithelium. There you go. And so it tells you about its modification that it has on its apical surface.
Not only is it pseudostratified, but it's also got cilia on it.
Okay, let's not talk about its function yet because we will as we move through.
And one other one we could use,
yeah?
keratin. Or keratinized.
I say keratin, or keratinized, yeah.
Keratinized.
But is that on the surface? That's embedded in the cell.
Yeah, but that just gives an additional name that I'm saying.
Oh, gotcha.
So when you look at stratified squamous,
Yeah.
it could be keratinized or non-keratinized.
Yeah.
And so keratin, being a protein, adds waterproofing.
Yeah.
So skin.
We'll get there.
Skin would be called. No, I'm just saying in terms of technical terminology, you would say the skin is keratinized, stratified squamous epithelium.
Right.
Because it's got waterproofing in it. Whereas if you look at the esophagus, which is also stratified squamous, it's non-keratinized.
Yeah.
Because it shouldn't be waterproofed because it is in water all the time.
Yeah. Okay.
Does that make sense?
It does make sense. I want to know some more apical features. You've said cilia. Is there anything else that can be on there?
You can have microvilli.
Right.
Microvilli.
So like fingertip-like projections.
Fingertip. Yeah.
Yeah. Because
that just
cilia beats, right? Like cilia has motile capacity to it.
Some do.
And usually in simultaneous motion. Generally.
Do you want to talk about this now or we come back to it?
I just want to say what it does, and then when we talk about the specifics, it will make a bit more sense. So cilia can beat.
Cilia can beat, so that's the motile form of cilia. So that can beat that
wave-like movements.
So that could be the waves of wheat in a field when a breeze of wind blows through it.
Yeah, okay.
That's
got a poet here, everyone.
That would be a motile form, but also the flagella at the sperm would be a form of cilia that is moving the cell in this case.
Yeah. And what about villi, microvilli?
Microvilli, these are just, again, membrane projections out.
Like fingertip-like projections.
And
but they don't move around, do they?
No, but they improve or increase the absorptive capacity of that cell.
By simply increasing the surface area.
Yeah, and so this is quite, when I came across this, it was quite surprising.
Yeah.
Some microvilli on one cell has got 15,000 microvilli projections.
Per cell?
Per cell.
15,000 per cell?
Yes. Isn't it amazing?
Oh, boy. So, and what do you think the average size is of a epithelial cell? Obviously in the microns.
Yeah, in microns. Oh, I don't know, maybe 10 microns?
Yeah, I'll try and figure that one out. So that, and obviously that, its entire job there is to increase surface area.
Yes, that's right. And that's how you would have that huge capacity for absorption in your gut.
Wow.
When you think of your gut, it just is like a 7-meter tube. But
did you say 10 micrometers?
10.
Yeah, it's good. That's it. Average epithelial size is between 10 to 30 micrometers in diameter. Good job.
So to have those additional projections, microvilli, would just improve or increase the surface area for that absorption of
Any
water.
other features?
Oh, then you can have other features. You mean outside just projections?
Yeah.
Well, you could have things like enzymes.
Right.
So they're producing, and I think in the microvilli case, correct me if I'm wrong here, these enzymes would be maybe secreted into the microvilli, and this is what is termed brush border, right?
Mm-hmm.
And as nutrients that you've consumed in your food meet the brush border enzymes, they can then undergo further modification. So an example being, let's say, disaccharides, where let's say you've just consumed some dairy.
Yeah. So let's say sucrose.
Well, I was going to say lactose.
Okay, lactose.
So lactose being a galactose and a glucose bonded together, as this molecule moves towards the microvilli, in the microvilli would be lactase, which is an enzyme that's been created there by the apical surface, presumably. And then that would cause the lactose to undergo a modification into glucose galactose, and then that can be absorbed across the microvilli, in through the cell, across into the blood supply, and then off to the liver.
Yep.
So enzymes is one.
Yep.
Ion channels would be one, which is going to be important for those specialized receptors that are picking up, sound or vision or mechanical deformation.
And not even just that though, like most cells of the body have particularly excitable cells, and I know that's muscle nervous, which aren't epithelial,
but
glandular are excitable cells as well, and they are modified epithelia. But epithelial cells of certain parts of the body, like the kidneys or the nephrons specifically, require sodium potassium ATPase pumps. And so they require the ability to transport ions from one side of the membrane to the other. And interestingly, when you look at the epithelial cells of the nephrons in the kidneys, so remember the kidneys filter our blood, and then we filter 200 litres of our blood we create 200 litres of filtrate from our blood, but we don't pee that out, right? We reabsorb 99% of it back into the body, and the way that we do that is through the epithelial cells of the nephrons in the kidneys.
And would that be microvilli as well? To a small degree, maybe.
Maybe to a small degree, but my point is that the apical side and the basal side both engage with transport of ions, nutrients, wastes, things like that. And so you've got the movement of ions, for example, on one end. So, for example, you can have the basal end having a whole bunch of sodium potassium pumps creating gradients so that the other end can transport either sodium ions, calcium ions, chloride ions, potassium ions, hydrogen ions, bicarbonate ions, whatever it may be, setting up gradients. So that's just an example of how epithelia can engage with and transfer and move ions.
Okay. Since we're here, I'm going to just finish off the last couple of points with the cilia.
Okay.
Because I don't think we'll come back to it, so I might as well just say it now.
Yeah.
So when you spoke about cilia, which are the projections from the apical surface of the epithelia, we spoke about the motile form, and we'll come back to that when we talk about the respiratory tract. But there's another type which is non-motile, which they call a primary cilia. And so this is some epithelium that just has a single projection like a antenna.
Right.
That just sticks out into the lumen of the extracellular environment.
The apical surface.
Yes.
All right.
And it's thought that they are like sensors for that particular area. So you may have ependymal epithelium, which are lining of the CSF of your central nervous system.
So that's cerebral spinal fluid. So they're the ventricles.
The ventricles and the whole way through the CSF transport system.
Yeah.
Now,
so the hollow inside of your brain, you've got ventricles, and the epithelia that line them are called ependymal cells.
Now, some of them may have,
and they've got these projections.
Some, not necessarily saying every single cell or every single epidermal cell, but interspersed in there, you're going to have these epithelium that will have these primary cilia that stick an antenna into that environment,
right,
and almost taste it. Ooh. So they're like receptors that are picking up that environment for chemical or osmotic or mechanical information,
right,
to feed back and tell the body what's happening there. So that could
Makes
be
sense.
in the bile duct, it could be in the kidney, it could be, as I said, in the CSF, and that's a function of that cilia, is to almost
observe what's happening in the environment,
to feed back and say,
very cool,
is there a problem or is everything okay?
Like it. I like it.
Now, the other one
is
a nodal cilia, and the only one I could find in this...
What was the other one called?
That was called a primary, because it's just one.
Yeah.
The other one are the motile ones.
Yeah.
Okay. Now, the nodal form, what this one does is it just beats around in almost doing a lasso.
Right.
You know, like a cowboy?
Yeah.
These cilia loop around like a lasso.
Right.
Now, the only place that I found, so it forms a rotational, like a whirlpool almost.
Really?
Yeah. Now, the location of where this happens is in the embryo.
Right.
In the time where we have the bilaminar disc, so that we have two layers of cells.
Yeah.
The top layer and the bottom layer.
Mm-hmm.
Now, this is moving from the second week into the third week.
Of embryological development. Yeah.
Now, on the top, so the bilaminar disc, the epiblast, you start to have these cluster of these cells starting to form.
What is the disc? Like what a...
It's just so basically have the egg that will be fertilized by the sperm.
Yep.
Then that will just be going up the fallopian tube, and all that's happening is just increasing number of
cells that are growing.
And by the time it gets to the uterus, at about a week, these group of cells cluster into two bands of tissue or two clumps of tissue, one on top of each other.
Yeah. Two clumps of cells.
And that's...
And this is the two discs you're referring to. And
that's right.
what does one ultimately turn into?
Well, the top layer, the epiblast, will become a lot of the epithelium, the skin and certain other specialized
Tissue.
Yep. The mesoderm, this is what I'm going to explain now,
Right.
what this does.
Okay, yeah.
And then the endoderm kind of just becomes the gut tube.
Okay. So where's this little
So
lasso?
there's a kind of a streak that starts to form. Okay. It's called the nodal streak. Okay. And this lasso kind of area where they have a cluster of cells with these nodal cilia that forms, which is almost like a plug hole. And so it's creating this rotational movement. And then what happens is all these cells from the top layer get sucked down the plug hole into the middle
like
layer.
when you pull the plug out of a bath.
Yeah.
Okay. Yeah.
And it starts to fill in between the two layers. And now you have the third layer, which is, this is in week 3.
Yeah.
And now we have a trilaminar disc, a third layer disc. And this is going to become mesoderm.
Which becomes
everything else.
Right.
So the majority of the
muscle,
embryo, yes.
Nervous system.
Now the nervous system comes from the epiblast, which is the ectoderm.
So muscles and other organ structures?
Yeah, pretty much everything.
Wow.
All the connective tissue, all that stuff comes in the middle
because
part.
of a single group of
lassoing
nodal cells.
cilia cell. Yep.
Beautiful. Beautiful. All right. Let's now talk about, because it's 41 minutes in and we haven't spoken about so where you can find each example of these epithelia that we spoke about. So just to recap, simple squamous epithelia, simple cuboidal epithelia, simple columnar epithelia, pseudo-stratified columnar epithelia, stratified squamous epithelia, stratified cuboidal epithelia, stratified columnar epithelia, and transitional epithelia. So I think what we should do is just go one by one, talk about its structure function. So talk about how form equals function, how its structure tells us what it does. We can then guess and impute where we can find it, and then talk about what it does in that particular area.
Love it.
So, simple squamous, what does it mean again?
One layer thick of flat cells.
Right, so it's very thin, like all these pancake cells, but they're not on top of each other, they're just next to each other. So, obviously, wherever that sits, it's not there to protect the underlying structure, right?
Yeah.
Because if you were to, it would be very easy to damage. It's just
right.
one layer of flattened cells. These flattened cells probably don't have much internal structure to it. Remember, inside cells, we've got the nucleus.
You mean like organelles?
Organelles, mitochondria, endoplasmic reticulum, Golgi apparatus.
So they're not making a lot
ribosomes.
of things.
No, they're not making a lot of things. It's simply there as a very minor barrier separating out the environments, but it obviously wants to interact with the environment. Otherwise, it wouldn't be thin. It wants things to go across it. It doesn't just want to absorb things and keep it for itself. It wants it to go all the way through it.
So is it diffusion?
Diffusion.
Okay.
So it wants things to go from one side of it to the other, obviously into the bloodstream, or to feed the cells that are on the other side of it.
Okay.
So where do you think we could have these types of cells or these types of
I think the
epithelia?
best example that we can use is the alveoles of your lungs.
Sorry, alveoles.
The alveoli.
Oh, right. And do you tend to have that with a tomato base or...
You mean ravioli?
Sorry, that's what I thought you were saying. Sorry. So the alveoli of the lungs, right? So the air sacs.
Air sacs.
Yes.
So this is where gas exchange occurs.
Yeah.
So here you really want in the carbon dioxide to come from the blood out through the cell, across the alveoli into the alveoli sac so you can breathe it out.
Yep.
And the oxygen goes the opposite way. It goes from the air you breathe down all the tracks to your alveoli, across these cells into the blood.
Yes. So gas exchange across simple squamous epithelia is a great example, and I think probably the best example of simple squamous epithelia and its function in letting things pass across it. So diffusion.
Now, I've got a couple of other examples.
Yes.
But it's not confusing, but the name then changes.
What do you mean the name?
All right. So,
as in it's not called simple squamous?
Correct.
What's it called?
I'll get to that now.
Okay.
So if it's one location of a simple squamous is in blood vessels.
Right.
Okay. So the lining of your blood vessels where is intimate with blood.
Mm-hmm.
Doesn't matter whether it is an artery or a capillary or a vein,
Mm-hmm.
it's still this simple squamous cell.
Yeah.
Now, when we refer to these, we don't call them simple squamous anymore. We call them endothelium.
And that's because they're slightly modified, right? Okay, so are they there for diffusion?
Things will diffuse across them in some places.
Yes, but not gas necessarily. I mean, it can, but it's not like the way that your body gets fed is through diffusion of your arteries or veins. It's simply through the movement of the gases. Well, it will diffuse through the capillary membranes, but it will be for other things as well, right? So,
And so that's one example. That's where it changes its name, endothelium.
Yep.
Okay, now you could be in the heart, so the lining of the inside of the heart, chambers of the heart. So this is where the blood is again in intimate contact with this simple squamous tissue. We don't call it simple squamous tissue of your atria or your ventricles. We call endocardium.
Right. And importantly, what's underlying the endocardium will be a very thin layer of connective tissue, but will be a thick layer of muscle tissue. And so it's not because it's there to allow for gases to diffuse and feed the muscles of the heart. They get fed through the coronaries, but it's there simply because epithelia must provide barriers. So you're not just going to have muscle exposed to the blood inside your heart. It just doesn't happen, right? You're always going to have this cellophane or cling wrap or whatever that's wrapping around it to protect it.
Well, the cellophane and the cling wrap is good for the next word. So the next term is a simple squamous that wraps the outside of the heart or the peritoneum or the pleura.
Right.
Okay, so this is the cavity now. So the cavity where your lungs are, we call pleura. The cavity where your heart is, pericardium. And the cavity where your intestines, stomach, all those visceral tissues are, peritoneum.
Now this is what I find tricky, right? They're simple squamous epithelia, generally 2 layers, right? You've got the
visceral and parietal.
Yes, you've got the layer that's most adherent to the organ, which is the
visceral.
Yep, and the one that's most furthest away
on the body wall, which is parietal.
Okay. But these simple squamous epithelia aren't there for diffusion per se. They actually produce and secrete fluid. Now,
but interestingly, they can also do absorption or diffusion.
Yeah.
And that's part of, an example is the peritoneal dialysis.
Yeah.
And so you can actually put fluid into if a person's got kidney failure, you can put fluid into their peritoneum and they can absorb fluid across into their blood and vice versa. So it almost works like a dialysis machine.
Right. So it's not just there to protect and provide.
But it does what you said.
Yes.
So it lubricates.
Yes.
And stops friction.
But maybe, and I need to double check this, maybe there are dispersed glandular cells between.
Yeah, you'd think so.
Because I wouldn't think that, and
like goblet cells.
I could be wrong, but I wouldn't think that it's the simple squamous cells that are producing the mucus.
And
right?
what's this termed?
Well, not mucus, but the lubricant fluid. What's what termed?
The lining of these body
mucus
cavities.
membranes.
Body. So we've said endothelium, endocardium. What do we call these that are the body cavity linings?
What do we call?
Mesothelium.
Oh, yes, of course.
And so you may have heard the cancer called mesothelioma.
Ah, yes.
Which is generally a risk factor for that is asbestos.
Yes.
So breathing in this fibre that comes, I guess it's natural, right? It comes from rock.
How does it affect the mesothelium if it's not going to be in direct contact with the...
Well, I guess it's breathed in. Somehow it gets absorbed across
the alveoli.
Yeah, it must somehow get across.
Yeah.
And then it sits in a place which becomes toxic to it. It just can't be removed. And then that causes the environmental change.
Okay.
Yeah.
So simple squamous. Are we done with simple squamous?
We're definitely done with it.
So predominantly though, simple squamous epithelia is there so things can diffuse across.
Yep.
Okay.
That's the best example, I think.
Next one is simple cuboidal epithelium. So it's one layer, and what that tells you again, if it's one layer, it's generally telling you that it wants something to get in or get out, right? Because if there's many layers, it's very hard for things to move across. So simple is going to tell you if it's squamous, it's for diffusion in and out. If it's cuboidal, Well, it's telling you it's cuboidal for a reason. It's cuboidal because it's going to have some internal components to it. It's going to have some organelles, and those organelles are going to do something. And generally, it's going to be either to produce something or to deal with something that it absorbs or to modify something, right?
Yep,
So
yep.
I think a good example of this is the cells of our kidneys, like our nephrons, for example. They're generally
tubules, yep.
simple cuboidal because, the tubules, because we want things to go into it, be modified, and go into the other side of it, and vice versa. It's not just to go all the way through unchanging necessarily. And also you can think about the surfaces of ovaries, sweat glands, anything else that you can think of?
Oh, just exocrine glands. Yep.
Okay, so define exocrine.
Exocrine is a glandular tissue that it makes something, but it secretes it into an external environment, which is most likely a duct.
Yeah. So anything
opposed to endocrine, which is into a blood vessel.
So these cuboidal cells can produce something that it can release into the hollow lumen of the environment it's facing, or it can absorb something, modify something, and then take that something to the other side, its basal membrane, particularly that if you're in the kidneys.
Yeah.
Any other examples you want to talk about for that?
No, I think you said.
All right. Simple columnar epithelia. So this is, again, one layer, but these tall, long, rectagonal shaped cells. Now, they're bigger internal environments, more organelles, more of a capacity to deal with either producing something for secretion or to modify something that goes in.
Right.
And so in this case, I like to think about the gastrointestinal tract because its whole purpose is to take larger foodstuffs, break it down into small, more manageable pieces that it can then absorb. Sometimes it needs to modify it in these columnar cells, and then it pushes it out the other side. If it's fatty acids, for example, it can push it into the lymphatic system. Lacteals. Or if it's like glucose or amino acids, it's going to push it into the bloodstream. But sometimes it needs to modify them before it does that, particularly those of the fatty acids. And that's one of the reasons why it's these big, long, columnar-shaped cells. But they also play a role in secretion. So, you've got these types of cells in the intestines and the gallbladder, and they produce, this viscous mucus fluid that it needs to release as well.
Yeah. Okay. So they're like the stomach pits, let's say.
Yeah.
Or gastric pleats.
Anything you wanted to add with?
No, I think gastrointestinal tract's a good one for that.
Yeah.
And so as we spoke earlier, these may also have microvilli on them to increase that absorptive capacity, particularly when you're in the intestines.
Yes. So again, the question that the student might ask is, why do some cells have cuboidal and why do some cells have columnar? If they both have internal, organelles, why one over another? And again, this is gross simplification, but the way I see it is that the bigger the volume inside, the greater the capacity to produce something for secretion or to deal with something that's been absorbed. So for cuboidal, again, that main place in the tubules of the nephrons of the kidneys, it needs things to cross the apical side and the basal side, but it also needs something to happen inside of the cell, whether it be a concentration gradient. If it's squamous, then you can't create a concentration gradient. There's no inside for you to create a negative charge or a positive charge, right? It's not necessarily going to be doing a lot of producing mucus or fluids or things like that because it's not big enough. It costs a lot of energy to produce secretions, and that's where the columnar come in. So the columnar is going to be able to deal with things on the inside a little bit better, and that's producing fluids and secretions and so forth, but can still take something in, deal with it, and push it through the basal end as well.
Yeah.
Is that all right, do you think?
Yeah.
Okay.
So then we go to the pseudostratified ones.
Yes.
Now, I think here the best example is the upper respiratory tract.
Yeah, I agree.
So these would be a cluster of cells that would have cilia on the top, on the apical surface.
Yep, so the beating eyelashes.
Yep, and interspersed in these cells would be a mucus-producing cell.
Yep.
So
goblet
cells. And so the reason for doing this is it's part of the innate immune system.
Mm-hmm.
And because we're breathing in the outside world effectively, we could be breathing in all sorts of kind of toxic or problematic substances,
Mm.
whether that are microorganisms or whether it's, dust, pollen, what we call it, mites.
Yes.
The poos are mites,
Ugh.
dust mites,
Right.
which is interesting. I was going to talk about this earlier, but dust mite poo causes the breakdown of the lateral surface adherence between each other,
Really?
and that can cause
Like leakiness.
leakiness, and they're more likely for individuals to get allergies.
So, like leaky endothelium.
No, the epithelium. So if you've got, let's say, you know how some people can get allergies to dust mites?
Mm-hmm.
Big part of the reason for that is because you're breathing in their feces.
Right. That's horrible to think of.
Within their feces is chemicals that can break down the adhering layers between the lateral surfaces of the epithelium. So where they're holding their neighbour tightly,
Yeah.
that chemical in the poo
Yeah.
breaks it down, which makes the protective layer less functional.
Right.
And that can lead to individuals' allergies.
Okay.
Yeah.
So,
And then that can be also, this can be also part of the reason for when people get infected by, say, gastrointestinal bugs like bacteria and viruses. That's one of their ways that they're producing toxic substances that can break down your protective layer of your epithelium, which then can take hold and then cause infections. Yeah.
All right, so we've got pseudostratified columnar epithelia in the airways. So where did you say again? Trachea?
Trachea, bronchial tree, but also in your nasal cavity as well.
Right. And you say that they have cilia on it.
Yep.
Now, because they're stratified, let's ignore the pseudostratified part. They're still stratified. It's just that they look like there's many layers. It's telling you that they've got a capacity to produce and secrete something, right? Like the mucuses, for example. So you've got these cells with the goblet cells producing and secreting mucus into the lumen, the hollow inside. It's viscous, it's sticky, it's there to capture, like you said, things that you inhale. And then the cilia, what's the point of the cilia then?
The cilia then, because it's motile, it will be moving in one direction.
So beating.
Yeah,
moving to a beat.
So like I was saying,
that's my beat on the table.
The wind blowing through long grass or...
okay, Robert Frost, just move on.
or fields of wheat.
Yeah.
It's pushing probably towards your pharynx.
Yes.
And then in the pharynx would be...
upward, against gravity.
So that what that would do is then it would be a method of you expelling that mucus with trapped foreign agents, whether it's bacteria or pollen or dust or anything that's nasty that you've breathed in. So and then typically you would then swallow it into your gut or into your stomach.
Or spit it out.
And that would then kill anything that's in there because the stomach acid is so strong.
Okay, so the mucus captures...
That's called the ciliary...
Mucociliary escalator. So the mucus captures anything that it doesn't want to get down to the lungs, and then the cilia beats it up into your pharynx so that you can swallow it or spit it out.
That's right.
All right, now
in your nasal cavity, it probably just dries out and becomes snot.
Yeah, that's a good point. Now let's talk about why it's pseudostratified, because that's a question that we always get from students. They'll always say, why isn't it just columnar epithelia? The best answer I can find for this...
I don't know the answer.
Oh, really? Okay, so the best answer I've been able to find for this is that being pseudo-stratified actually provides a slightly better layer of defense. Because the cells tend to be slightly overlapping, hence why they look pseudo-stratified, it's more difficult for them to be sort of torn apart.
Okay.
And therefore it's a better protective layer. So if you think about it, that area is still going to be exposed to a lot of environmental potential toxins or damaging particles or whatever it may be. So it needs to be as protective as possible. Ideally, it would want a stratified layer to be protective, but it can't, because if it's stratified, it can't really secrete mucus because there's going to be too many layers to move through. Not possible. So its best option is to be pseudo-stratified.
Yeah.
That's the best answer I can.
Okay, I like that. Now, should we just bring in here quickly the idea of the transformation of cell type?
No. Let's
Okay.
finish it and we'll go back and we'll use that. Okay, so what's the next one we're looking at?
Stratified. So now we go into the stratifieds now.
Okay, so this is now
Stratified
many
squamous.
layers. All right, so stratified squamous epithelia, many layers of squish cells.
So I think the best example here is the epidermis, so that this is the top layer of your skin.
So when I look at you, so like if I said, Matt, take all your clothes off immediately,
Too late.
right? Oh yeah. There you go. No, if people are watching YouTube, I don't think would be able
Would
to get
like to
past
see
this.
that.
No. We want our audience to learn, not vomit. So anyway, if you were to just get fully nude, regardless of
I'm a never nude.
oh really? So you cut off jean shorts. All right. Even in the shower. So if I were to look at any part of your body, I'm looking at your epithelia.
Yep.
Right. So when you fall in love with somebody, you're actually falling in love not just with their personality,
A dead person.
but with the epithelia. Okay, well that's a good point. So
Every part of you that I can see is dead.
all right, just
Hair,
all right, enough.
conjunctiva,
Yeah.
oral cavity,
Okay.
skin,
All right. And emotively.
nails.
All right. So listen, the squamous cells are squished. We
Yeah.
said they've got basically no internal components to them. That means that they also have no capacity to undergo metabolism. So effectively, by one definition, they're dead. These cells are dead.
Not all of them, but yeah.
Yeah. And because there's many layers of them, you've got many layers of, you could possibly classify dead cells.
Yeah.
Right? They're avascular. So if you were to cut them or damage them, you're not going to bleed. And they generally don't have nervous innervation through
No, they
them
do.
either.
They do.
Well,
The skin does.
yeah,
Not
but,
the cells individually.
but what I'm saying is that the stratified squamous layer of your skin does not have neural innervation.
Well, it's got nerve endings into it.
Not in the stratified squamous.
I think it does.
No, it's in the lower layer. So if you were to take...
Oh, you mean like the dead part?
Yeah, I'm talking
Okay.
about... So if you were to take the 5 layers
Yep.
of your epidermis, the most superficial layer,
Okay.
which is the... what's the stratum...
Corneum?
Is that the most superficial layer?
Yeah.
Yeah, there's no neural innervation in that.
Yeah, okay. I agree with
Right?
that. Yep. I was just seeing it as a collective.
Okay.
So because we're saying stratified squamous here, example is the epidermis, right? The whole layer of the epidermis, even though it's classified as a stratified squamous, it goes through different kind of properties. So the bottom layer, right at the bottom,
Mm-hmm.
okay, the basal layer is probably more cuboidal shaped.
Yep.
Yeah. And now as you move, and those cells are alive.
Yep.
Okay, that's a stem cell of your skin. That as you move up, what is it now?
So from stratum basal, then it's stratum spinosum.
Spinosum. So
Yep.
they're also alive.
Yep.
Okay, then lucium, is that right?
Then there's stratum lucidum.
Lucidum.
But
so,
they're only really, that lays only really on the palm of your hands and soles of your
So they're
feet.
see-through,
Yeah.
and they're technically still alive.
Yeah.
Now you're moving to dead cells, right?
Stratum corneum.
Corneum, but
Yeah.
there's one more, isn't there?
Nope.
Okay, so the top layers. So you're right. The top layers are just flaky dead cells.
Yeah.
So that wouldn't have a nervous supply. But I'm just talking about the skin epidermis, which is still classified as stratified squamous tissue.
Not all of them though, that's the thing, right? That's my point, is that, like you said, the basal layer, and you could possibly argue that the spinosum layer are cuboidal.
Yeah, but
Right.
but I'm just saying when you have an example, when you're in an exam,
When academics fight.
when you're providing an example of stratified squamous tissue,
Yeah.
right? The classic example that you would give would be epidermis.
Would be the most superficial layer of the epidermis.
Yeah, but I still think the epidermis is classified as a stratified squamous tissue, but unfortunately, to be in morphology, the bottom layer is more cuboidal.
I think you're right by bulk. So for example, if you were to take those 5 layers of the epidermis, so let's just, so that people have this in their head, because they're probably going, what the hell are these morons arguing about, right? You've got your skin. Right? And when we talked about the skin, people are like, yeah, I can see your skin, right? But the skin or the integument is actually made up of a multitude of layers. You've got your epidermis, which is all epithelia, and then you've got your dermis, which is going to be connective tissue, muscle tissue,
Blood.
nervous tissue, right? So let's just talk about the epidermis, the most superficial layer. Again, it's epithelium, and it's made up of those 5 layers: stratum basal, spinosum, lucidum, basal, spinosum, granulosum.
Yeah,
We
granulosum.
forgot
I knew that.
granulosum, lucidum, and corneum. So there's the 5 layers, and that's going from deep to superficial. The stratum corneum is very squished, and the layers are like 30 to 50 layers deep, but the rest are like 1 to 2 layers deep.
Mm-hmm.
So when you look at the bulk of it, yes, the bulk of your epidermis is stratified squamous.
Yeah.
All right, but
That's the way I've always done it.
Okay, and you're right. There's going to be neural innervation that goes up into the spinosum and granulosum, but not up into the corneum. Right?
Agreed.
Yeah. Okay, but the whole point of this is they're basically dead because there's nothing inside. They're not doing anything. Is the main point, and they're there simply like creating a brick wall to protect what's happening inside to outside. If you hit it and cut it and graze it and damage it,
Burn it.
No big loss, right?
It can grow back. Yeah.
But if you start to move through into the deeper layers,
Yeah.
right, you start to go from the corneum into the spinosum, granulosum, lucidum, or basal layers, then you're going to start to feel something.
Mm-hmm.
And then if you go even deeper into the dermis, you can bleed.
Yeah.
Right?
Or that in that case, yes.
Now, as a bit of a digression, but not really, your mum's skin cancer was of which of these types of cells?
It would be not in the basal layer because that would be a basal carcinoma.
Yeah.
That's affecting the stem cell of the skin. But it would be the next population up, which would be the spinosa,
The spinosum.
spine-like. I think it's in that cluster of cells, which they can also reproduce, I believe, as well.
Mm.
So the cancer would be in that. Now, in her case, what needed to happen as those cells started to become dysplastic, so not really appearing like they should, they then have the capacity to, and this is what happened to her, move in basally or more deeply, and they were able to migrate through the basement membrane.
Right.
And then once it gets through there, now you're invaded. So it
Close to a
becomes
blood
like
supply.
a carcinoma in situ to an invasive carcinoma,
Yeah.
which now is why so much tissue needed to be removed.
You've basically got access to highways,
Yeah.
right? Blood vessels, lymphatic tissue. and
Now,
you
the
can
squamous cell
move.
carcinoma is the second most invasive. If we're going to just call the skin cancers 3 main types,
Yeah.
basal cell, squamous cell, melanoma.
Yeah.
But the melanomas are the most aggressive. They come from the melanocyte, which is not an epithelium of such.
Mm.
It's a pigmented cell that throws melanin into the mix to
Yes.
help with protecting the basal cell, which is the mitotically active cell in the epidermis.
Yeah, protecting it from UV light,
UV
which
light.
can damage DNA.
Right.
And obviously, you don't want to damage the DNA of the basal cells because they're stem cells. Because if you damage that, you've now damaged a cell that can possibly lead to the creation of a whole bunch of damaged mutant cells, which is not a great thing.
Correct.
Right. Okay, so we've done that. It's there for protection. Is
Yep.
the stratified squamous?
And just one big difference there, and we said it earlier, you could have keratinized or non-keratinized.
Oh, yeah.
So the skin is a good example of keratinized because the top layer is all keratin.
Yeah.
Whereas if you're looking in the esophagus or the oral cavity, that's going to be non-keratinized, which is non-waterproofed.
Yeah, good point. Stratified cuboidal epithelium. Many layers of cube-shaped cells. So this is a tricky one because we said that there's something inside and it wants to produce or absorb something, but if there's many layers, it's very difficult. Generally, you find these cells lining ducts.
Yeah.
So, for example, if you have a look at a tube of the gastrointestinal tract, for example, you might find as you go through this tube that there might be what look like divots or crypts or grooves that go in.
Pits.
And if you follow those pits, if you follow these Brad pits, you'll find that the cells that line them are stratified cuboidal. And generally, they play a role with producing and secreting into that pit. So they could be salivary glands, they could be sweat glands, they could also just be glands that produce secretions for the gut or mammary glands.
An interesting one I come across with halocrine glands.
Which is?
Halocrine glands.
Oh, hello.
So these would be sebaceous glands of the skin, but also Mebian glands or the
What's that?
eyelid glands.
Oh, okay.
So they produce like a fatty, lubricating fluid.
To protect the eyes.
Correct.
Right.
But interestingly, with these type of glandular cells, they produce all their secretory products within the cytoplasm.
Yeah.
But as they are ready to secrete, they undergo apoptosis, so a controlled form of death.
Wow.
So the cell starts dying, releasing not only the secretory granules but also the contents, which becomes part of their...
So its job in life is to produce one batch of secretion
And then die.
and then
Die for the team.
Wow. Well, there you go. So it's its gift to the world before it passes.
Yeah.
Wow.
Isn't that beautiful?
How generous. Yes. Stratified columnar.
Yeah.
This is an interesting one. It is a very rare type of epithelia. You don't really find it in many places, but the one place that you can find
Sweat
it really
glands.
is... Oh, really?
I don't know.
I was going to say the male urethra, and also the conjunctiva of the eye.
Oh, the eye.
Right? And again, a bit of secretory function there. But it's not common, and it's probably just a byproduct of the location.
Yeah, okay.
Right? And then finally, transitional epithelia, which...
Best example is the urinary bladder.
Yeah. Sorry for ruining it earlier, by the way, by stating that.
Okay. No, I didn't. I can't
You say
remember.
that's okay, Mike. Remember, you were talking about what transitional epithelia are, and I said, like the bladder. And you obviously refrained from saying the bladder because we're going to do it later. But
That's the urinary bladder, not the gallbladder.
correct. But anywhere for distension, hollow, lined by epithelia, needing to distend and come back, it's just going to have from possibly columnar to cuboidal to squamous. That's the various layers. But it's just so it has the capacity to change shape.
So if you were holding on to your urine,
Yeah, just
You
in my hands,
you,
like,
you
like
couldn't
this.
make it to the toilet.
Yeah.
Have you ever had to hold on for so long your bladder goes numb?
Well, I don't know about numb,
I have once.
but I've had it so that it was actually difficult to initiate the wee.
But then when you wee in, you lost feeling to...
Oh,
kind of-
yes.
You can't feel it coming out?
Oh, if you wee for long enough, yes, if that's what you mean. I've been busting so much that I've probably got 12 litres of urine, obviously not,
I did it
sitting
once.
there. And you peed for so long, I'm like, I don't know if I'm still peeing or not.
I did it once at a football grand final. I wasn't playing, I was a spectator.
Okay.
But I had such
But you peed onto the pitch.
but I had such a good seat. I didn't want to give up the seat.
Right.
So I sat there for...
Why would you give it up? Someone would just snake your seat if you left.
Yeah, because it wasn't like NRL, it was a local football game.
Right, but you had a good spot.
And it was a good spot. And I knew my mates who were behind me, they would just steal it.
Right.
So I was like, I'm going to hold on to this. By the time I got to the toilet, because then even after the game, everyone was using the portaloos.
Right.
So I'm like, I've got to hold this till I get home. Then when I finally did it,
Yeah.
I couldn't feel it coming out.
Wow.
But I was there for like 2 minutes.
Wow. Like Austin Powers when he first gets defrosted. I think he wheezes a fair few times there.
So my question here is, when
Yes.
it's so full,
Yeah.
what would the cell layers look like? Just all squamous.
I suppose so, because they'd be as stretched out as possible. Would they?
Wasn't one
Wouldn't
of
it be the other way around?
Wasn't one
When
of
you see
the
the-
famous philosophers or one of the famous scientists in the Enlightenment period supposedly die from
His bladder.
bladder explosion because he couldn't go to he was at dinner with the royals?
Oh, the astronomer.
Yeah.
The Dutch astronomer.
Yeah.
What is his name?
I reckon that's false
It's on
though.
the tip of my tongue. Yeah, I think so. I don't like. I mean,
I think you just wee yourself.
theoretically, your bladder can burst, but that's from trauma,
Yeah.
right?
Or poorly inserted catheters.
Catheters, yes. It's not going to burst from holding your pee. Probably the worst thing that would happen is you just piss yourself.
Yeah, I think you'd piss yourself before your bladder bursts.
Yeah. All right. So we've gone through that.
That's all the layers.
That's all the
Done.
layers.
Wrap it up.
Now, okay. We will probably do another podcast on pathologies on the skin because we do need to talk about dysplasia, metaplasia, and things like that.
Basically, what...
Yeah, let's just do a definition of that because I think that would be a good finisher.
So
for us.
the two terms here, metaplasia and dysplasia, are commonly associated with epithelium.
Yeah.
Because the reason for epithelium change in form is that they are generally associated with a stem cell that
Mhm.
reproduces epithelium.
Mhm.
Okay. So these epithelium that we spoke about, they usually have a cell that helps renew them.
Yeah.
Okay. Now, In metaplasia, this is meta meaning to change, I guess.
Yep.
Basically what's happening here is there's an environment that changes, in a way, stimulus to the stem cell, and the stem cell tries to change its morphology to suit that environment.
Yeah, that's right.
And so the best example would be your airway, again, pseudostratified ciliated epithelium.
Yep.
But if you were to expose it to tobacco smoke,
Yeah.
so smoking cigarettes for long periods of time, that environment is toxic to those cells.
Yeah.
And they say, look, this is not great.
Yeah. I'm supposed to be producing mucus here. That's why I'm columnar.
And I need these cilia.
To protect myself.
And so not only does the tobacco, it actually paralyzes the cilia. So the cilia are just like frozen.
Yep.
They can't beat anymore. But they need to become more protective like.
Yes.
So the stem cell says, bugger making any more
Columnar cells.
ciliated cells. I'm just going to make stratified cells.
Yeah.
And I'll just throw brick layers on here.
Yeah.
Protect it. And this is part of the reason why a smoker can't expel foreign agents anymore.
Yeah.
And rather they rely on a cough. That's the smoker's cough.
Yeah, exactly. So metaplasia is changing of a cell into an established cell type in order to protect it ultimately.
Of an environmental stimulus.
Yeah. Okay.
But it is reversible. So
Alright.
it can change. Another good example is the esophagus.
Oh, yeah.
When you get a lot of reflux.
Yep.
It's changing from a stratified squamous into a type of a columnar that's more like what you'd find in the stomach.
Yeah, because it's like, I'll try my best to secrete something that neutralizes this acid.
Yeah. Or protect it.
But it's not effective. Okay, so that's meta. Dis. So the dis as a prefix is telling you that it's problematic.
Disordered,
Yes.
dysfunctional.
That's right. So this is a change in cell type, but generally into an abnormal
Now
cell
this
type,
has become this is now termed a pathology.
Okay. So there's abnormalities associated with the change.
Yep.
It could be a structural abnormality or a functional abnormality or a problem with the internal components are abnormal.
And in many cases, this is termed precancerous.
Gotcha.
So if you were to look at a biopsy of a tissue that's dysplasic, they would potentially say that this is precancerous. Not quite cancer, but on the way to.
Yeah.
So again, you could use the example of the esophagus, and it's now changed metaplastically to dysplastic.
Yep.
So what would start to happen is, I think it's called pleomorphism. So you now have, instead of one cell type being a change from stratified squamous into columnar, now you have all these weird cobblestoning.
Right.
So you have cuboidal, columnar, squamous, all in this group.
Yeah.
And so they're a mixture of everything, and plus they're also highly mitotic. So they're replicating quicker.
Yeah.
And so that's part of what cancer will become, is an uncontrolled growth of cells.
And this will lead me to the last point of the podcast, which is the reason why most cancers are cancers of epithelia is due to that particular reason.
So the most common cancers in Australia,
Yeah.
in terms of by percentage frequency, would be breast cancer,
Right.
prostate cancer,
Yeah.
lung cancer,
Skin cancer.
colorectal cancer, skin cancer.
Skin cancer. So
All-
top 5,
All are
epithelial.
epithelium. So
the
breast
reason-
cancer,
Yep.
either lobule
Yep.
or ductal, but they're epithelial. Lung,
Yep.
generally the lining or the alveoli. Bowel would be the lining or the glandular.
Yep.
Skin, 3 types.
Yeah.
Melanomas, basal cell, squamous cell.
Yep.
Was there one more that I missed? Prostate.
Prostate. Similar
Usually
to
glandular.
Yeah. And the reason why, twofold, or at least there's probably more, but the main reasons. One is that these are the cells that are exposed to the environment, right? Because they create the barriers. And so if they're exposed to the environment, they're going to be exposed to whatever is being brought into that environment. So again, whether it be smoke for your lungs, whether it be other form of toxins through your digestive tract, they're going to be the areas exposed to the environment. That's the first thing. Second thing is that because they're exposed to the environment, they're often killed off quickly and damaged and need to be replenished. And so the stem cells that underlie epithelia to make more, they undergo the cell cycle often. And the more you undergo the cell cycle, the more likely statistically you are to have a mutation put into your genetic material, and therefore increased likelihood of a cancer arising. So there's two mechanisms.
And also on top of that is as you age, you have more errors in the system, right?
Yes.
It's just less efficient as it was when you were born, let's say.
Exactly.
And so it's just getting tighter and tighter.
Yeah.
And your immune system is less efficient at cleaning up mistakes as well.
Exactly right. Now, if you made it to the end of this podcast, we need to say a couple of things. First thing is, if you've sent us an email and we haven't said anything, it's because our website is screwed up. Something is wrong with our email.
It's dysplasia.
It is. For the past couple of months, we have not been able to access emails sent to our website.
So we do apologise.
gubiosciences@gmail.com. We do apologise. We're trying to fix this ASAP. So if we haven't got back to you or we haven't acknowledged your email, simply know that's because we haven't got it and we're so sorry. Next thing is you can contact us. Let's just try social media at the moment if you like, which is at Dr. Mike Todorovic, at DrMikeTodorovic on all social media platforms, Instagram, TikTok, Facebook, Twitter. Come say hi. And apart from that, we'll try and get the email fixed.
Or you can email directly if you need to, gubiosciences@gmail.com.
Oh, that's true. Yeah, do that directly.
But through the website, it's not working at the moment.
Yeah, don't do it through the website. Do it straight from the email. It's gubiosciences@gmail.com. And we really appreciate your support. Give us a 5-star rating. Leave a comment. Tell your friends. Share it all. We love you. We do this for free. And, you know, we care about every single one of you.
That's true.
It's true. We want you all to learn about the body and be as well informed as possible. And as you can see, we try not to talk all about that other crap where we're trying to say, hey, here's a tool for your longevity, and hey, we're going to give you a protocol where you stare into the sun for 5 minutes.
I was going to talk about
morning.
that today. That cryotherapy. That
cryotherapy.
Freezing
Cold
yourself.
therapy.
Freezing yourself.
There you go. Well, that's what they do to cancers. They freeze them. All right. Thanks, everyone. We'll speak soon.
Bye.
Bye.